Hi, everybody. Welcome to the Community Health Nurses webinar series for 2023-2024. Today's webinar is called It's Time to Talk, Increasing HPV Awareness and Prevention with Your Patients with Dr. Nancy Durand. As I'm here, I might be asking people who are in the waiting room. I might have to admit a few people. We have 93 people who have joined us so far, which is great. It's really a pleasure to start this webinar today. So I'm going to start first with the land acknowledgement. I'm calling in from Toronto, but please take some time to acknowledge the land that you are joining us today for this webinar. So from Toronto, and I know that Nancy, our speaker, is from Toronto as well today. We're in the Dish with One Spoon territory. And this is a treaty between the Anishinaabe, Mississaugas, Haudenosaunee, and it bounds them together to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. So today's webinar is part of a series called the Vaccine Across the Lifespan webinar series, and this has been generously supported by an unrestricted educational grant from Pfizer, Merck, and Sanofi. After today's webinar, you're going to receive an email. The email is going to be, and you might not get it today, but you'll get it in the next few days. It will be to complete a survey just so we can get some information about about the webinar, about where participants are coming from, and a little bit of background about what you found helpful from the webinar. And there's also going to be a certificate of attendance that's emailed to you as well. You just need to fill in your name and keep this for your own records. So please watch out for that email after the webinar. These are some of the strategic priorities for CHNC, the Community Health Nurses of Canada. And I just wanted to bring this to your attention. And so the first one is advancing the health of people in Canada. Our second priority is strengthening Community Health Nurses of Canada as an organization and as a center of excellence in community health nursing. And our third priority is to build an effective organization. So today's speaker is Dr. Nancy Durand, and Nancy is an associate professor in the Department of Obstetrics and Gynecology at the University of Toronto in Canada. She received her medical degree from McGill University in Montreal, Canada, and completed her residency in obstetrics and gynecology at McGill University. She is on staff at Sunnybrook Health Sciences Centre in Toronto and in the Department of Obstetrics and Gynecology. Her clinical practice focuses on HPV and colposcopy. She speaks nationally and internationally about human papilloma virus and HPV vaccination. So I'm going to now pass it over to Nancy Durand, and thank you very much.
Thanks so much for that really nice introduction, Barb. Let me know if you have any trouble hearing or seeing slides, everybody. Barb,
it's great. It's perfect.
That's the problem. And I really am happy to join for this afternoon, and for some people perhaps earlier in the morning, depending on the time zone that you're within. Especially in this particular group, as you all work as part of a team of people providing healthcare to the public, you play a very large role in health prevention. And this is one of the areas when we talk about HPV that you need to start knowing about, and I'll explain why. So these are my disclosures. And as Barb mentioned, I work at Sunnybrook Health Sciences Centre in Toronto, which is a large teaching hospital in Toronto. And I also hold a few other hats that I wear. I speak and I act on advisory boards for Merck, not just in Canada, but globally as well. So we work on advisory boards talking about the role of HPV vaccination in health prevention. And I also work for the Moderna Global Advisory Board. That's more recent, where I work on a board that's looking at emerging mRNA vaccines, not just for COVID, but for utilizing that technology for other viruses as well. So that's some interesting work that I'm lucky enough to be involved in. So what I wanted to do this afternoon and this morning is talk about an overview of the recent trends of HPV diseases, including that of head and neck cancer. I want to talk about the public programs that we are fortunate enough to have in Canada and some of the limitations of those programs. That leads nicely into a discussion on adult HPV vaccination, including males. Want to look at our recommendations in Canada and the position papers on HPV from several medical societies, and finish up with some practical tips on how we can counsel for HPV vaccination, especially if we're not used to that type of counseling. So first, I want to start by describing the burden of disease that is increasing when we think about HPV-related diseases, and wanted to bring everybody sort of up to the same level of knowledge. So we'll do a little bit of basic stuff first. Well, HPV is the most common sexually transmitted infection around the world, and that's true no matter where you live. So where I live in Ontario, that's true. Where you live anywhere in Canada, but also that's true in any country that you live in globally. More than 75% of us, and probably closer to 90%, will have at least one HPV infection during our lifetime. And if we looked at any one snapshot in time, between 30 and 60% of adults are infected currently. And I'll talk to you about why is there such a range there? Why do I say 30% at the low end and 65% at the high end? Now, there's more than 100 types of HPV. It's not just one thing, as a lot of people sometimes think. There's about 40 that infect the anogenital tract, and we divide those into low risk and high risk types. The low risk types are those shown in blue, the most common being type 6 and 11, and they cause about 90% of external genital warts and a lot of the low grade precancers that we see on the Pap test on the cervix. And then there's high risk types seen in red, which are going to cause some of the low-grade cervical dysplasias, but will cause the high-grade cervical dysplasias, as well as the invasive cancers, including cervical cancers and the other cancers. So if we look at what might happen to a person if they're exposed to HPV, so this is actually a great tool that we use when we're talking to patients about their diagnosis. Number one, you might become an asymptomatic carrier of HPV. So you have virus, it's not doing anything to you, but you're able to transmit it to your partner or partners. Number two, you might develop external genital warts. And number three, you might develop precancerous cells of the cervix, or cancers of the cervix, or cancers of other sites. So if you're female, you could develop cancer of the cervix, vagina, vulva. If you're male, you could develop penile cancer. And both females and males can develop cancers of the anal epithelium as well as of the mouth and throat, which is the oropharynx. Worldwide, HPV is reported, meaning estimated, to cause about 5% of all cancers in men and women, including those sites that we just discussed. And in addition, we have to remember, besides cancer, HPV also causes non-malignant disorders, such as external genital warts, as well as in children, recurrent respiratory papillomatosis, where they get benign papillomas on the vocal cords. Now, we face many challenges in the areas of screening and diagnosis, reporting and surveillance in many areas of the world who may not have these programs available like we do in Canada. So these globally reported numbers are actually much lower than the actual number of cases. And of course, if you think about it, cervical cancer is the only one of all of these diseases that has a method for screening so that we can detect and treat people before it becomes cancer. If we turn now to Canada, the burden of HPV-related diseases is seen here, and a few points you want to think at when you're looking at this slide. Our eye is often drawn to the top of the pyramid. We think that's where we're supposed to look, but in fact, that's not the most important part. It's the least important, because the burden of disease is going to be at the bottom of the pyramid. And as you'll see, external genital warts far outnumber all of the number of cancers combined. You can see also in this slide, the number of cases of oropharyngeal cancer caused by HPV has now surpassed the number of cases of cervical cancer diagnosed every year. You can see for anal cancer, the number of cases in women outnumbers the number of cases in men. So this is an interesting, more recent change. The reverse is true for oropharyngeal cancer. There are far more cases in males than there are in females. So we'll talk about why are those reasons. Now, what is our risk of exposure to HPV as an adult as we get older if we might have a new partner? On the left, we can see the prevalence of HPV in women gradually declines with age, but not to a value of 0. In fact, if you look at the age of 50, the prevalence of HPV is still around 35%, so it's pretty high. And then if we look on the right panel, it's even more interesting. In males, we have a higher prevalence of HPV, around 65%. And this does not decline with age like it does in women. It's a steady prevalence regardless of how old we are. So the risk in males is actually quite high. Now, we do know that the patterns of sexual behavior in women are changing, and because of this, the risk for HPV in women is increasing. This particular study looked at a group of more than 500 online daters who were mid-adult, so up to the age of 65. They're online daters, and a quarter of these women are over the age of 40, so not just younger women. When we looked at prevalence for high-risk HPV or oncogenic HPV types, it's quite high. And more than 40% of these women had more than one type of high-risk oncogenic HPV. And interestingly, unlike this previous slide, their prevalence did not decline with age. It was more like the male pattern of HPV infection. So women are now at higher risk because of their changing patterns of sexual behavior. Traditionally, HPV has really been thought of as an issue that just affects women because of its known link to cervical cancer. That's what we all remember. However, this burden of disease is shifting. HPV-related diseases in males are increasing. Specifically, all of the HPV-related cancers in males are rising: anal cancer, penile cancer, and oropharyngeal cancer. But as I mentioned, the challenge is we don't have any recognized or recommended screening methods for these diseases to find them in males before they become cancer. Now, anal cancer incidence in both males and females has been rising over the past 2 decades. And we see these increases in anal cancer in all races and at all stages of diagnosis. And one group of women who's at particularly high risk for anal cancer caused by HPV is women who've been previously diagnosed with an HPV cancer, such as cervical cancer or high-grade cervical dysplasia. So they are at very high risk in the future, about 10 years later, for anal cancer, especially if their cervical disease was caused by HPV-16. Now, the most common location for HPV cancers of the mouth and throat, or the oropharynx, is all at the back of the throat, the tonsils, base of the tongue, and the soft palate. And unfortunately, it often will present with a painless swelling in the neck, which is an enlarged lymph node. And this, of course, is a sign that the cancer has already spread. Treatments for oropharyngeal cancers caused by HPV might involve surgery and often require extensive chemo and radiotherapy with considerable side effects. So while the mortality rates from this cancer are good, you don't tend to die of it. The morbidity is very high from the treatments that we do. So it leaves people with ongoing pain, difficulty swallowing, difficulty eating, and difficulty drinking. In the United States, HPV-related oropharyngeal cancer in males has more than doubled over the past 2 decades, and the same thing is being seen in Canada and other developed countries around the world, such as Europe, Australia, UK. Interestingly, the rates of oropharyngeal cancers from HPV in females have remained relatively stable. Now, the HPV vaccine was recently approved in Canada for prevention of oropharyngeal cancer, not just for prevention of cervical cancer and anal cancer. So this is now an added indication, an added use that we recommend HPV vaccination for prevention of oropharyngeal cancer. The number of HPV-related cancers of the mouth and throat, as I mentioned, is significantly higher in males than it is in females. It's about 4 to 5 times higher in males. Now, the prevalence of oral HPV infection or virus is also higher in males than it is in females, which may in part explain why they're more at risk for these oropharyngeal cancers. And if we are to plot the declining rates of cervical cancer, so it's been declining at a rate of about 2% per year over the past few decades, against the rising rate of oropharyngeal cancer caused by HPV in males, we can see the curves have actually now crossed. This effect has been seen in all developed countries in Canada, the USA, Europe, Asia, and around the world. And so it means that we really need to start thinking of HPV as not just a female problem, certainly as a gender neutral problem. And one could even argue that it's tipping in the favor of being a male predominated disease. We often hear both patients and providers say, well, if they've already had or been exposed to HPV, they're going to be protected against future infection because they'll make an antibody response. And some people would believe then the natural antibody response means you're not at risk for future HPV infection. But remember a few things. HPV is not just one virus, but it's a group of many strains of virus. And having one HPV infection does not protect you against the other strains. But what about the one that you do have and those antibodies that you might make? So let's look at that antibody immune response to HPV. So when natural infection to HPV occurs, not everybody makes an antibody response. And in women, in fact, only about 50 to 60% of women develop antibodies to natural HPV infection. And in males, it's much lower. Less than 20% of males will make antibodies to any of the 4 types in the quadrivalent HPV vaccine. And if you look at the most important one, which is type 16, less than 5% of males make an antibody to natural infection with HPV 16. So what about if they do make an antibody? For those few people that do successfully develop an antibody response, does it protect them from subsequent infection? In fact, it doesn't. There's no difference in subsequent infection rates for those who become seropositive, who make an antibody to their HPV type, compared to those who did not develop any antibodies. So these antibodies, when they do develop, are not protective for future infection. They're just a marker of past exposure and infection. I'm going to spend a few moments talking about transmission of HPV to partners, because people often ask you about this phenomenon. So interestingly, when we look at transmission, the rate of transmission is higher from females to males than it is from males to females. So this once again shows us that males again are particularly vulnerable to transmission. And as have we seen, they don't develop good antibody responses to it either. In one study, the Hitch study, which was published in 2019 from McGill, which was a prospective cohort study of heterosexual couples, they found that vaccination could decrease transmission from a person who's HPV positive to their partner who's HPV negative. So this is one additional benefit of vaccinating, as well as helping ourselves. We may be able to reduce transmission to our partner or partners. So now I'm going to turn to the vaccines themselves and look at approval and recommendations, especially looking at some of the age limits, because we get confused when we're talking about age for vaccination. And there is a distinction between the approval and recommendation for HPV vaccines. They're not quite the same thing. 3 vaccines for HPV have been developed over the years, which protect us against either 2 types, type 16 and 18, that's the bivalent vaccine, or 4 types, 16 and 18, same as the bivalent, plus the 2 most common low-risk types, type 6 and 11, and then down to the 9-valent vaccine, which protects against 9 types, including the 2 low-risk types, 6 and 11. Remember, I told you they cause 90% of external genital warts, and the 7 most common oncogenic or high-risk types of HPV. In Canada, the original quadrivalent vaccine is now off the market and has been replaced by the 9-valent vaccine back in 2015. And those dates are important for me when I'm talking to somebody who says, oh, I already got that, I already got HPV vaccination. I'm going to pin them down and try to ask what year or what grade were you in, what age were you? Because if you say you were vaccinated before 2015, I know it was an older first generation vaccine. And as I'll show you, I will talk about the benefit of 9-valent vaccine in that individual. So quadrivalent, as I said, was the first vaccine licensed in Canada by Health Canada, and that was in 2006. And originally that was for females aged 9 to 26. Later, this was increased to age 45 for quadrivalent, The bivalent vaccine called Cervarix type 16 and 18 was approved in 2010 for type 16 and 18, just for the following female indications. And now in 2015 and onward, the 9-valent vaccine was approved by Health Canada for the following female and male indications. So cervical disease, vulvar and vaginal precancers and cancers, anal precancers and cancers, external genital warts, and now oropharyngeal cancer prevention. In 2020, the male age, you'll notice, was increased to age 45 to match the female indication. So now adult males, not just under the age of 26, but adult males over the age of 26 could also be vaccinated. That's approval by Health Canada. Now we're going to turn to recommendations. So NACI, the National Advisory Committee on Immunization, after Health Canada approves a vaccine, then makes statements for us about who they feel should and shouldn't be vaccinated with any immunization. So with respect to HPV, NACI has always recommended HPV vaccination in those from the age of 9 to 26. And now you'll see it's individuals. Sorry, there's going to be an announcement over my head. Just give me a sec.
Your attention, please. Your attention, please. Protected. Code blue. C Charlie Wing, 3rd floor, room 42, bed 1. Your attention, please. Your attention, please. Protected. Code blue.
Sorry.
C Charlie Wing, 3rd floor, room 42, bed 1.
Knew it was going to happen, and they'll cancel it in a couple of minutes twice. So we'll stay tuned for that. So NACI has supported vaccination over the age of 26 for several years now with no upper age limit. NACI feels very strongly that the age of 45 was only because that was when the original clinical trials stopped enrolling people. It is not to say that it stops working over the age of 45. So for that reason, NACI gives us the freedom to prescribe and immunize those, both male and female, from the age of 9 with no upper age limit. And they have always recommended vaccination for those who have a current or past history of HPV-related diseases. The Society of GYN Oncology of Canada went one step even further with stronger language, actively recommending universal HPV vaccination in Canada, not just supporting, but actively recommending. So now what about the logistics? We give 3 doses of HPV vaccine at 0 months, 2 months, and 6 months. And that is if you are 15 or older, age at first dose. Our kids in schools get 2 doses because they are 14 and younger, age at first dose. If you miss a dose during your series, we resume where you left off, no matter how much time has passed. So even if a year, 2 years, 3 years has gone by within the series and you come back, then I will just resume where I left off with dose 2 or dose 3. I want to talk about the provincial programs in Canada. So in Canada, all provinces and territories now vaccinate gender neutral, so both boys and girls in our school-based programs. Different grades depending on which province you are living in. For example, in Ontario, where I live, it's grade 7, and in all other provinces, it tends to be at an earlier grade, which is a good thing. The earlier, the better. All provinces vaccinate with 9-valent vaccine, except for Quebec, who gives the first dose of 9-valent vaccine. The second dose, 5 years later, will be bivalent vaccine. All our provinces and territories have funded doses for men having sex with men, but only 6 regions have funded doses for those living with HIV. And for me, this is a particularly sad statement because it means that women living with HIV are not covered in my province for HPV vaccination. Men living with HIV are, because they usually fall into the group of men having sex with men. So in terms of lobbying, this is certainly an area that we all should be lobbying our government if it's not available for those living with HIV in our region. We have catch-up programs in several regions. British Columbia has funded vaccine to the age of 18. And if you start by the age of 18, you can complete your doses funded by the age of 25. In Ontario, we have funded HPV vaccine until you leave high school, till you finish grade 12. And we have a special additional catch-up for the first 3 years of kids after high school, meaning years 1, 2, and 3 following high school, but that will be finishing in August of this summer. And you have to have completed to have funded doses by August of this summer. We hope that may be extended, but we don't know that yet. And Quebec has a girls catch-up program to the age of 18. Now, Alberta, Yukon, and Northwest Territories are very interesting in that they have funded vaccine for all up to and including age 26, gender neutral. So that, again, is something to aspire to. And the reason I mention this is that although all children in Canada have funded doses, our uptake is not optimal. So for example, if you look here in Ontario prior to COVID, 2018-2019 school year, our uptake continued for HPV to be less than 60%. Now, many other regions have better uptake than we do, especially if they vaccinate at younger grades. So for example, Newfoundland PEI have much better uptake rates in the neighborhood of 90%. And then of course, these programs were all halted as school was shut down during COVID. And our uptake rates plummeted. And even with catch-up programs, for example, in Ontario, our uptake rate with catch-up is only about 25%. So we really are falling behind in our vaccination programs and falling much farther behind some of the success countries like Australia and the United Kingdom. Sorry, I just advanced there. So this means that we really do have need to go beyond just our school-based program and to vaccinate adults as well as the children in the school-based programs. The rationale for vaccinating those outside the school-based program, there's 3 main benefits. We know there's risk of new exposure, and we want to vaccinate before the exposure happens. Just like in kids, in adults, we would prefer to vaccinate you and not wait for the exposure to happen. It has been proven to reduce disease in adults as well as in younger individuals, as I'll show you. And even if exposure's already occurred, vaccination is still of value and it reduces recurrence of disease in those who've already been exposed. So let's start with looking at the evidence for vaccinating adult women. The original clinical trials, which were done in younger women, showed almost 100%, 97% prevention of infection disease. And we now have clinical trials done in mid-adult women over the age of 26 using both bivalent vaccine and quadrivalent vaccine. And as you can see, almost 90% reduction of persistent infection, external genital warts, as well as abnormal PAPs. And this is just in the first 4 years after the randomization of the clinical trial. Years 4 to 10 is the long-term extension of adult women trial and no breakthrough cases of vaccine type HPV infection. So long-lasting effect, even if we're vaccinating at an older age. And we're now starting to see actual evidence of not just reduction of precancers and external genital warts, but actual reductions of cervical cancers. This landmark paper from Sweden, which was published 3 years ago, studied 1.5 million girls and women in Sweden, wide age range up to the age of 30 who were being vaccinated over an 11-year period, and looking at the incidence of cervical cancer in those who were vaccinated compared to those who were not vaccinated. The cancer rates in those who were vaccinated were almost half the rate of those who were not vaccinated. And yes, it's true if you're younger when you're vaccinated, the rate reduction was much higher, 88% reduction. But even if you were vaccinated up to the age of 30, still more than 50% reduction in the incidence of cervical cancer. In the United Kingdom, we've seen similarly very large reductions in both high-grade cervical dysplasia, CIN3, as well as in cervical cancer when we compare the vaccinated cohort to those prior to the HPV vaccine programs, the unvaccinated cohort. And similar findings have been published now from Finland and the United States, but these 2 papers are by far the largest studies to date. So now we're going to turn to look at the clinical data for vaccinating males over the age of 26. And as I mentioned, now 3 years ago, a 9-valent vaccine was approved by Health Canada to vaccinate both over the age of 26 as well as under the age of 26. The male trials for HPV vaccine can't look at cervical dysplasia because they don't have a cervix. So what you look at instead is external genital warts, and they also looked at high-grade anal precancerous cells. And these results, again, were very dramatic and seen very quickly after only 2 to 3 years, almost 90% reduction of external genital warts and 75% reduction of high-grade anal precancerous cells. And just like in the female trials, the long-term extension phase followed male participants up to 10 years. And again, after the first 4 years of the study, from years 4 to 10, no breakthrough cases of disease were seen caused by the vaccine types of HPV. So we've looked at vaccine trials for anogenital disease, but do we have evidence for the impact of vaccination on oral HPV? In fact, we did have a hint of this many years ago, 10 years ago, in the original bivalent vaccine trials done in younger women. When they looked at the vaccinated women compared to the placebo women, they found more than 90% reduction of oral HPV type 16 and 18, the two worst kinds, in those who were vaccinated compared to those who were not. And we now can actually see the real world impact that HPV vaccination is having on oral HPV infection. In papers from the United States and the UK, we are already seeing declining oral HPV prevalence in younger females and males who have been vaccinated. We still need to study on the adult side those people over the age of 20. And this large multi-center placebo randomized control trial is now in the phase 3 portion of the trial, is underway in male adults up to the age of 45. And this is being done in 5 countries around the world, and it will be completing its study next summer in 2024. So we're very much looking forward to this study because it's being done in older individuals and the previous has been done in younger. Now, as I mentioned, we often think it's too late to be vaccinated if you've already been exposed, meaning if you've already had infection or disease. And it's not just patients that think this. I can tell you that people I work with, providers, often think this too. So is there any value in vaccinating those patients that we've had who previously have or currently have disease? Well, now dozens of studies have been published showing that HPV vaccination can reduce the rate of recurrence of abnormal PAPs in those who've undergone treatment for abnormal cells. And these findings are not just limited to the cervix. In fact, vaccination has been shown to have the same effect, reducing recurrence rates of external genital warts as well as high-grade vulvar precancerous cells. And it's not just limited to females. We see the same effect in males. If we vaccinate males who have had high-grade anal dysplasia or external genital warts, we can still have significant impact and reduce their recurrence rates. So when you think about it, we must remember that we should not exclude anybody on the basis of their gender, on the basis of their age, or on the basis of past or current exposure to HPV-related infection or disease. All of these people should be counseled for the value of HPV vaccination. These findings, in fact, have led many jurisdictions such as Spain, Italy, Austria, and here in Canada in Manitoba and PEI to now recommend and fund HPV vaccination for those being seen in colposcopy, or in the case of PEI, for anybody who has an HPV diagnosis. So now I want to move and finish up with some of the strategies for counseling for HPV vaccination. Remember, the rationale and the reasons that we have reviewed that are valued for patients who are adults to be vaccinated also hold true for the patient's partners. Remember, in adult males and females, HPV infections are common, new infections do occur, and recurrence rates are high because most men and many women don't make natural antibodies to HPV. We know that we can reduce infections that you've not been exposed to. We know we can decrease recurrences in those with a past history of HPV-related diseases, and we may decrease transmission to partners that you have or that you will have in the future if you carry HPV. So when counseling adults, we find this following strategy can be quite helpful and clear. This is a vaccine to protect you against cancer. HPV cancers are preventable, and we don't want to lose you to this disease. Now, you'll notice I didn't say anything about this being a sexually transmitted infection. I talked about this being a vaccine to help prevent cancer. Couple of other points we need to remember. We shouldn't assume that a young adult, male or female, was already vaccinated in our school-based programs. Because, for example, in my province, I know about 40% of kids are not vaccinated when they leave high school. So there's a very large cohort of kids in their late teens, early 20s that missed HPV vaccination in the school, and I should still counsel. And remember, when we counsel adults about the value of HPV vaccination, these adults are also parents or may become parents in the future. And the chance that they will consent their children in our school-based program is higher if they understand the value of vaccination in themselves. We need to do a better job at increasing parental consent in our school-based program, and this is one of the tools that we can use to do that. We need to look for little windows of opportunity to open this HPV vaccination discussion. And it depends what practice we are in. When are those types of conversations naturally occurring? Obviously, any contraception discussion is a great way to introduce HPV vaccination. And in fact, any STI testing or talking about external genital warts. Travel vaccination, you might be a bit puzzled by why is that a reason? Well, we know when we travel, the likelihood of having a new sexual partner is actually quite high. So it actually should be part of a travel vaccination discussion. Any preventive health discussions, such as flu shots, that COVID shots now that we may be having. Mental health visits is an interesting time that we should remember about this, because remember that mental health visits often go hand in hand with a change in relationship status. So we shouldn't forget that it's a good time to counsel about prevention of infection, including HPV, and that includes vaccination. Anybody who's doing preventive maintenance, such as executive physicals. And I think we can learn a lot from the very successful campaigns that we have in November for male-related cancers. We probably, with HPV, should do something similar for HPV-related cancers, or certainly female cancers. Most importantly is, although we talk for 30 minutes about this now, we really need to keep our messaging simple with patients. There's really three things they want to know. They want to know, number one, does it work? They want to know, number two, is it safe? And we forget that number three is one of the most important parts of them getting successfully vaccinated. Do you recommend it? The strength of your recommendation is what will successfully get the person vaccinated. Just like COVID vaccines, our patients are looking to us to know that HPV vaccine is a trusted vaccine. I wanted to finish up with a few approaches that I take for those frequently asked questions that we all get. How about this one? I'm too old. Why are you talking about this with me? HPV vaccines are just for kids. Well, number one, the person in front of you might be thinking that because it's offered in the school-based program, that's when you're supposed to get it, and that you don't get it outside of the school-based program. And that's not true. It is available, just not funded by the government necessarily at older ages. Number two, they might think because they're older, it's not going to work. It's not successful. And we know that clinical trials have shown excellent efficacy and duration in adult females and males. How about my child doesn't need to get HPV vaccine because my child is not sexually active? We have to flip that conversation and say, this is the perfect time for your child to be vaccinated. In fact, this is when we want them to be vaccinated, before they're ever sexually active, even if they're only sexually active with one partner the rest of their life, because we can't screen the exposure of that partner. You could also remind parents that we use a seatbelt to avoid injury in an accident. We don't wait to have an accident to use our seatbelt. It's a great analogy. I don't need to get vaccinated because I'm married with kids. So yeah, look at me personally. Why am I vaccinated? Because I am for HPV. I'm married. I have 2 kids. Sadly, the statistics are not always on our side. We know that more than 50% of marriages are going to fail in one way or another. And we don't always know within a marriage or a monogamous relationship if a new exposure has occurred. That may be with or without our knowledge. And thirdly, eventually one of the two in the partnership will pass away. The chance that we're going to have a new lifetime partner is extremely high. And just like with adolescents, we want to vaccinate before that occurs and not wait for it to occur. Now, I hear both. I won't get HPV because I always use condoms. Or how did I get HPV? Because I always use condoms. Well, remember, condoms decrease the risk for HPV, but they don't prevent it 100%. They reduce it by about 70%. So vaccination is actually a very important adjunct in reducing risk in addition to barrier methods such as condoms. Well, it's too late for me to get the HPV vaccine as I've already had HPV, or I have it right now. As we mentioned, many clinical studies have shown that we can reduce the recurrences of HPV diseases by HPV vaccination, so we can improve your future outcome and decrease the chance of you having to come back for more treatment. So we should not be excluding these patients. In fact, the reverse, we should be actively really recommending vaccination, especially to these patients. How about I got one dose of HPV vaccine and I forgot, or I was away, I went traveling in Europe, or I was pregnant, because that's a time where we don't give vaccine. As I mentioned, we were going to resume where we left off, no matter how much time has passed, except for this particular situation. What if I got one or two or all my doses of original bivalent or quadrivalent vaccine? Should I get the 9-valent vaccine? This is one time where, yes, I do tell you that I will discuss 9-valent vaccine with you, because 9-valent vaccine covers 20% more strains than did bivalent and quadrivalent vaccines that cause cancer. So you have 20% risk reduction by adding the 9-valent vaccine to one of those original vaccines. And then the person says, well, do I just need one dose? Because I already had 2 or 3 doses of bivalent or quadrivalent vaccine. The answer is no, because there's 5 new oncogenic types that the 9-valent vaccine protects you against. You need 3 full doses of 9-valent vaccine. So I would give a full series of 9-valent vaccine if the person had a previous bivalent or quadrivalent vaccine. And I do discuss that with every patient that I see if they've not been vaccinated with 9-valent. The choice is theirs, but I do discuss it with every single one. The question that a lot of people find the most difficult: my patients can't afford this vaccine. And we often assume that our biggest barrier to getting patients vaccinated is cost. You might be surprised. In a national survey that I was involved in with the Society of OBGYN of Canada, we asked the same questions about HPV to providers, including both family doctors and specialists, as well as patients. And we asked them, what is the #1 barrier to your patients getting vaccinated? More than 90% of both family doctors and OBGYN said cost was the #1 barrier. And the interesting thing is, if you ask the patient the same question, only 18 to 20% said cost was their #1 barrier. What they did say was the barrier to them getting vaccinated was my doctor or provider never talked about it or recommended it. So in reality, the perceived barrier of cost may not always be the actual barrier. And that means we should not prejudge who can and can't afford this vaccine and not talk about it. We must provide accurate and up-to-date information to each patient so that they can make their own informed consent. The actual cost of HPV vaccine in Canada is generally about $200 per dose. Now, you'll notice that's how I list cost. I don't say this vaccine costs $600. I talk about cost per dose because that is how you pay for it. You pay as you pick up each dose. Once the series is completed, no further doses are needed. So there's no booster dosing that will be done 5 years, 10 years later. We do mention that private drug plans, about 40 to 50% in Canada, cover it. And you could, if you don't have that yourself, your spouse's plan might cover it, or your parents' plan. A lot of plans also have flex dollars or health spending accounts. And if the drug is not covered, if you have a health spending account or flex dollars within your plan, you can use that for anything you want, and you could spread the cost over 2 calendar years. You could spread your doses over 2 calendar years. And remember, the cost of an HPV-related diseases is always going to be more than the cost of prevention. I'd like to finish now at that point, and I will stop sharing so that I can see questions, comments, and we are going to stay online as long as you need us to answer questions. Thank you.
Thank you for that, Nancy. Really appreciate a wonderful, wonderful presentation. So if people have questions, they can put their hand up and we will unmute them, or we do have a number of questions in the chat. So I will start with the first question and Karen and I will alternate.
Thanks.
So the first question is, if an individual was vaccinated with the HPV vaccine prior to 2015, would they require a booster to cover the additional high-risk types? I know you discussed that.
Yeah,
But...
so prior to 2015, that would have been a bivalent or quadrivalent vaccine. They don't require a booster if they're completely vaccinated, but what they're vaccinated to would be type 16 and 18 if it's bivalent, or 6, 11, 16, and 18. If they want to do 9-valent vaccine, and I would recommend it to them, they would not just get 1 dose, they would need to get 3 doses to be covered for all of the new types in the 9-valent vaccine.
Great, thank you.
Hi, it's Karen Curry. I have another question for you here, and I think you may have just answered this similarly, but just want to make sure. My children went through high school before it came out. They are in their late 30s, should they go? And I think you discussed that the age limit has been in most provinces has been dropped, but to advocate if they want to. Is that correct?
In all provinces and territories in Canada, because NACI is federal, you are permitted to have HPV vaccination with no upper age limit. And everybody always then asks me, well, what's your upper age? Like if you're in your 50s, 60s, 70s, I don't have an upper age limit. So do I vaccinate people at these upper ages? Yes, I do. But I'm also a person that sees the disease. So I see people coming in with new abnormal PAPs, age 60, 70, 80. And if I talk to them, a lot of the time I will say, have you had a new partner in the past couple of years? And the answer is almost always yes. There are a few exceptions where it could be reactivation of old disease. That's still helpful to be vaccinated to reduce recurrences because we know that it helps. So I don't have an upper age limit. And the answer is yes, both boys and girls, no matter who you are, I would discuss vaccination regardless of your age.
Great, thank you.
Thanks, Nancy. The next question is wondering why there is better uptake with earlier age introduction.
It's a great question. And so I think it makes sense to me that when you drop the age, especially to grades 4 and 5, the parent thinking about this vaccine is thinking about it a vaccine for health, not a vaccine with anything to do with sexual exposure. And so when we talk about vaccines for health, people are much more accepting of them in general. And so when we push it in Ontario, it used to be grade 8, now it's grade 7. Grade 8, it was only girls, it was grade 8, age 13 to 14, and the whole discussion was onset of sexual activity. And it was really unfortunate at grade 8, because if you look at Canadian stats for kids reporting their own sexual activity at age 13 to 14, 30% of them have been sexually active. So you've already had potential exposure in 30% of kids, and it doesn't have to be penetrative vaginal intercourse. It can be any type of intimate contact, genital skin touching. So when we push the age lower, the parent isn't worried about why am I vaccinating my kid about sexual exposure. They're thinking about it for health. Also, pediatricians are excellent vaccinators. When you go to the pediatrician and you're talking about vaccination for your kid, what they do is they tell you the schedule, when you're going to do what. They don't say, do you want to? They tell you what's going to happen. Very strong recommendations. We all listen, and they get their patients vaccinated successfully. It's when we're waffling and we feel uncertain and we don't give that strong recommendation. That's where our problem exists, I think.
Thank you, Nancy. That's a great response.
Great, another question here. Does the enhanced early screening, or that might be vaccination, have anything to do with reduction of HPV in younger males?
Enhanced earlier screening, sorry?
Yeah, that's what's the question, and maybe whoever.
I'm not sure what enhanced earlier screening means.
Oh,
Yeah.
it's Erin here. I was just wondering if that had any relevance to either picking up, like for the research. I just wondered if, because you mentioned there was no actual screen, like there's no PAPs. So the
No.
screen for genital warts, if there was more of that, would that have any reduction of any relevance to the research?
I still don't quite understand the early screening part. 'Cause
So
we're not doing early screening in males.
so when they have active genital warts, that's when they come in? Is that when they're presenting?
That's
To-
when anybody's presenting. Yeah.
Okay. So,
So if you want to look at vaccination, yes, it has had reduction in Australia and in the UK, dramatic reductions of external genital warts in both females and males. We don't see nearly as much reduction in Canada because our uptake rates are lower. Where in the countries where we have very, very high 90% uptake of HPV vaccination, they've almost eliminated external genital warts in those countries very rapidly. Canada needs to do a better job in increasing our uptake in all our provinces and territories, but especially those ones like Ontario, which does not have good uptake rates.
okay, thank you.
Hey, the next question. I requested vaccination from my doctor at the age of 19 and was denied as I was in a monogamous relationship. Super disappointing. Sure, I ended up marrying the man, but who would have known at the age of 19? Missed my funded vaccine age due to this. Do you find it harder to convince patients to get the vaccine when it isn't covered by the province or insurance program?
So it all depends how you talk about it. Do I have trouble? No, I don't, but that's what I talk about. I'm good at it. My talk is very, very short. And I repeat my talk because the people that I see, I'm typically seeing them once or twice a year. Within my electronic charting, I made into it myself a reminder that I discussed it and then that I gave a prescription for it. I give them a handout for it. So it's verbal. I have a written handout. I give them the vaccination and I tick off that I discussed it, or you've had 1 or 2 or 3 doses and when you completed it. And on every visit, I do that. And they know that I'm going to talk about it on every single visit. And sometimes they're really funny. They say, you know, I thought about it last week. I knew you were going to talk about it. So I went and I finally got my first one because I know you keep asking me, have I been vaccinated? So it depends upon your approach. No, I don't have trouble. If cost is an issue, remember 1 dose is better than 0 doses. 2 doses is better than 1 dose. So even if they can't afford 3 right now, 1 is better than nothing. You can spread your timing out if you have to. It's not optimal, but you can. If you could get the first 2 doses at the proper time intervals, that's the best. The 3rd dose could be given even a year later and still be very effective.
Great, thanks, Nancy. We could learn from you, I think.
Yes, so much great new information. This is fabulous. Have another question here, and this is really pertains, from our community health nursing focus, remote and rural, and particularly northern communities. What would you suggest for health promotion of HPV vaccines in remote northern communities?
So we know in the Yukon, it's actually funded up to and including the age of 26. So I think number 1, in our remote communities, we should try to get the other territories on board the same way. It would be really, really effective. We need to we find it's more successful to bring vaccine to the people versus bring the people to the vaccine. So I remember in residency when I was at McGill, one of the staff guys that I worked with, and now it's somebody from Ontario, I can't remember who, does outreach to Iqaluit. And 4 times a year, one of the chief residents, there was a raffle to get in to be one of the 4, would get to go up to Iqaluit with that person. And at that time, they would bring in the patients to Iqaluit from, I think it was 12 outpost communities. And this idea of trying to bring to the people or bring vaccine to their remote communities, I think would probably be much more successful because certainly cervical dysplasia and cervical cancer is very high rates in the remote communities, as is HIV. So I think that from the medical community, we need to really think about approaches to bringing vaccine to the community when possible, especially in remote regions.
Thank you, Nancy. That makes a lot of sense. Another question is, what kind of campaigns are currently active to address the different age groups publicly?
Well, I think our approach probably needs to be more universal, that we're not identifying specific groups at risk, because as I showed you, we really should be vaccinating all sexes, all ages, over the age of 9, period, whether you've had disease, haven't had disease. We can look to industry to do promotional materials. Public health, I wish could do more than, I just know public health with COVID has been so overwrought with other kinds of work. A lot of this type has fallen off quite a bit. So I think that our opportunities as different organizations outside public health, outside industry, probably we need to do a better job in public campaigns to let people know this information. So I think that's an area that we could all work on.
Great. Well, you're talking to the right group of people here that want to help you in spreading that message. And we had over almost 184 people, I think, the top number that we had. So we'll spread that message for you. So another great question here. Do you anticipate that there'll be any clinical trials to include age groups, particularly those over 45?
I don't think so, because they've already proven that they're very expensive and large trials to run. And so I don't think they're going to bother with over the age of 45, because many countries around the world, including the EU, just in many regions, just have no upper age limit. And so that's sort of the approach that most have gone to, is to just have no upper age limit.
Great, thank you.
Okay, there is a question here about the slide deck being available to those who attended, and we are recording this, and the recording will be made available to those who have attended.
One thing I would ask is, please don't duplicate the slides. I spend a lot of time. These are my slides. They're not industry slides. And I've seen it before in another talk where pops my slide. So
oh no,
you're welcome to use them for information, but I would ask that you don't copy. You'd be amazed.
Absolutely. We certainly put that on our information when we send out any of our recordings and whatnot. So I think we have time for one final question. There's one here in the chat, and I'm also checking if there's anyone who wants to another question. This is someone from out west, from Calgary. They've had a really great immunization program. Biggest challenge with HPV refusals is around the concerns of potential fertility issues for girls. Sorry, am I scrolling here? Do you have any tips? And of course, as you spoke about it encourages and condones sexual behavior in young adults. Do you have any tips for addressing these without dismissing the parental concerns? And how can we work in the school system to help promote the vaccination?
Yep. So no studies have ever shown any fertility issues in girls that have been vaccinated, or boys for that matter, because it really should include both. And several papers have shown that those who have been vaccinated have less sexual activity, young adults, than who have been vaccinated. Probably you're vaccinating a group of individuals who tends to be more aware, who has agreed to be vaccinated, but there's actually decreased sexual behavior in young adults who are vaccinated. So it's actually the opposite of what some parents may think. And we often pause and say to that parent, if we were talking to you, I'm going to have, sorry, an announcement.
Your attention, please. Your attention, please. Protected. Code white. D Delta Wing. Sorry. 3rd floor, room 51. Your attention, please. Your attention, please. Protected. Code white. D Delta Wing. 3rd floor, room 51. Okay.
He'll come on in a minute and cancel it. Sorry, let me just think again. The parent, there was something I wanted to say. Shoot. We were talking about the permission. What was I saying? We're not dismissing.
Not dismissing the parental concerns and the evidence around early sexual activity.
Yeah.
And the vaccine.
No, it wasn't that. Oh, I had something good. Shoot. I'll think about it. Oh.
Not so your announcement gone there. I think we got some great comments here in the chat, and a few folks have posted they're doing some work on First Nations, and they have adapted messaging for their community that they're working with, and sharing some of that information. And I think that's all of our questions. Did I miss any?
There's a couple of other questions.
Oh,
So
okay, came in behind there.
One
Okay.
that said, can you recommend print material that would be appropriate for older age groups?
So there is print material from Merck, who makes the 9-valent vaccine for adults, both male and female. If you go to the SOGC website or hpvinfo.ca, they also have excellent materials for HPV vaccination. You have to be careful, Canada, for the US over the US, because the US has somewhat weaker recommendations for adults, where they sort of pulled back, and it has to do with funding. If in the US, if they recommend HPV vaccination over the age of 26, the insurance company must cover it. So you'll sort of find the wording is a lot softer in the United States, and that all has to do with funding. Canada doesn't care about that. So NACI just makes recommendations based on evidence, which I think is probably better. There was an interesting comment, and it's true, in Alberta, there is talk of other disciplines providing and recommending vaccinations, such as dentists. So dentists and pharmacists are two areas where we're very excited about them talking about HPV, because dentists are the ones who tend to diagnose the oropharyngeal cancer, because you're going twice a year, and it's not even a dentist, it's your dental hygienist who's looking in your mouth and checking the tonsils, base of the tongue, and soft palate. That's exactly what they're doing, and they're finding cases every year. Pharmacists are very interesting. In many regions, pharmacists can give this vaccine in Canada. And so the patient doesn't even have to come back to me as the provider to be vaccinated. I can talk about it. I can give a prescription. They can do the vaccinating, and they're very good at it. And their record keeping is excellent. They inform me that the vaccine has been given, and they're good at reminding people to come back for their other doses. So I do love those models of, just alternative methods of getting this vaccine out there.
Right, and that's really good. And we do have one more question. Sexual health counselor by phone and chat here. We speak with a lot of folks who do not have a family doctor and access walk-in clinics. What is a quick blurb for us to better prepare callers to advocate for themselves to get access to the vaccine if they are over the age of 45, when they might get some pushback if the practitioner is misinformed about when vaccine should be administered?
Well, it used to be nobody knew who NACI was, and now everybody knows.
Yeah, exactly.
And not just providers, but the public knows who NACI is, and that's the secret, is to say NACI supports vaccination with no upper age limit. If that patient is to say that, it's true, because a lot pharmacists also sometimes cut off at the age of 45 because they're reading Health Canada. And again, I go back to that pharmacist and say, actually, we have no upper age limit by NACI in Canada, and then they allow it. So the secret is usually that NACI recommendation.
Great, thanks, Nancy. I know we're over time here, and I think that was the last question that I could see. So Karen, I'll turn it back over to you.
Great, thank you so much, Nancy. Certainly very informative. And as I said, previously, you've got a lot of folks who heard this message, can take it back to their area of work, their area of practice, promote the new information that you shared and some of the clarification. And we really appreciate you taking the time to share your knowledge and your passion for this work. And I know this has touched me in my life and with young teens, thinking about how to, continue the conversation, and thankful that the vaccine is available to prevent disease. So thank you so much. We're really appreciative, and lots of great comments and discussion in the comment section, folks going away with new information. So thank you so much.
Thanks so much, everybody.
Great. And for folks from CHNC or other community health nurses, please stay tuned. We'll have other webinars that are coming up. We have some coming up in June, and we'll be posting that on our internet. And our AGM is coming up for those of you who are members on June 14th. So we hope to see you there as we continue the good work that we're all doing to support our communities moving forward with good wellness messages and education and research. So thank you so much. Stay tuned for upcoming webinars. Thank you.
Thanks.